Hello and welcome to Inside View. I'm your host, Joel Metzger, and joining me on the show today is Dr. Randall Smart. He's a practice in Murphy's, and he's a board-certified internist in the Chair of Medicine for Mark Twain Medical Center. Dr. Smart, welcome.
Thank you, Joel. It's great to be here.
Well, it's always a pleasure to have you on the show. We have continued to do a series on all kinds of different medical topics, and tonight we're going to be talking about sleep apnea. So, can you tell us a little bit about sleep apnea?
Well, what we know, Joel, is over the last probably decade, there has been a sort of this epidemic of obesity in this country. Americans are getting bigger and bigger. We're really concerned about that. And the numbers vary, but as much as 30 to 40% of our country could be defined medically as obese. A big number. And with that obesity, there are what you might call unintended consequences. And so as people develop these bigger weights, we're seeing more and more problems that are weight related. Examples of that would be more and more joint pain and joint disease from the weight on joints, more diabetes because there is an association between the two, more hypertension, high blood pressure. So lots of unintended consequences related to the obesity epidemic. And one of these is really a mini epidemic within that, and that is obstructive sleep apnea. As people get bigger, they have more and more problems with sleeping and managing their breathing while they're sleeping. And in an average day in a clinic, like my clinic today, you can see 4 or 8 people who have obstructive sleep apnea just in one day's work.
Are there different kinds of sleep apnea? You said obstructive. Is there another kind too, or is that?
There are. If you look at the textbooks on sleep apnea, there are variations. There's something called central sleep apnea, and there's other sleep disorders. But the one that seems really related to the obesity is obstructive sleep apnea.
You've mentioned what I'm assuming is the main cause. Is that obesity, or are there other causes as well for obstructive sleep apnea? There are other causes. So you might say, who gets this disorder? And it's really interesting. Anybody can get it. You don't have to be obese. So you and I think, are probably normal weight. You or I could have this. Anybody could have this. Younger people can have it. Men can have it. Women. But there are people that tend to be more predisposed to it, and we know as people age, they're more likely to have it. Clearly, their weight is related. People with more medical problems, such as heart failure or diabetes, tend to have it. And actually, men have it much more than women. Any clue as to why that is?
Not really, because it doesn't necessarily, it's irrespective of weight. Men just have more. And if you look at the numbers, something like 30% of men across the board have obstructive sleep apnea. 1 in 3, huge number, right? And the number is about half of that for women, about 15%. Now you could speculate that maybe that has to do with behaviors, but I don't think we really know. But there are people that are much more inclined to have obstructive sleep apnea.
You mentioned that age can be a factor. Is there any cutoff age where you might start to be at a much higher risk?
There probably is. I can only tell you the anecdotal answer, and is that we tend to see, I see most of this between 40 and 60 years old. It almost seems like that's the age where our people are heavier, and After about 60, 65, we see it taper off some. You rarely see it in the real senior citizens, like the 80, 90-year-olds. You don't see much of it there. But sort of the middle age, the 40, 50, 60.
And is there any reason why it would drop off as you get older? What's changing that would cause it not to be a problem anymore?
Well, it may be weight related. I mean, you could speculate about this too. Is that maybe the people with obstructive sleep apnea don't live into older age, and we could talk about that. So they don't get older. But we also know that as people age, and around 60, 65, weights tend to start dropping again. So that would be my guess, is that as they really start to age later, they don't weigh as much and they don't have as much sleep apnea.
How would someone know if they have sleep apnea?
Well, great question. You may not know you have it because some of the early signs are things you may not associate with that or recognize as a sleep problem. Now, one of the most common symptoms is fatigue. Hey, doc, I'm tired. I'm tired all the time. And usually my answer is, so am I. But actually, fatigue, people that have daytime fatigue are people that probably should be screened for sleep apnea. So you could just be tired and you could say, well, I'm a working mother, or I've got 2 jobs, or you could have a lot of sort of rationalizations for that, but in the end, that may be because you're just not sleeping well at night. Other things that you would maybe not associate with it is poor concentration. So if you weren't concentrating as well at work or daily activities, that could be a sign. Memory memory and sleep are very well correlated, and people that don't sleep well don't have good memories. And then sometimes it can be things like early morning headaches. People that wake up with headaches could be from sleep apnea, and it has to do with oxygenation during the night. So it could be subtle, and you may not know you have it. People that have self-educated about it correlate it very strongly with snoring, and there really is a strong correlation with snoring. People that snore are much, much more likely to have it. But not everyone snores, and not everybody with sleep apnea has snoring. And if you sleep alone, you may not know you snore. You may, so you may not know you have it, but those are things that people should think about as being related.
Can you walk me through exactly what's going on when someone is experiencing sleep apnea? Can you paint a verbal picture for us?
It's fascinating. It's absolutely fascinating. So we sleep at night, and we think it has to do with reprogramming of the brain and memory organization, and it's critical. It's interesting. If you look at the medical literature, if you don't sleep, you will die. People that are 100% sleep deprived die. And there are diseases where that happens, and that's not what we're talking about tonight. But sleep is just absolutely critical. And so what happens in a sleep apnea patient is they initiate sleep. Probably most of them sleep on their back. And then what happens is they tend to have sort of a loss of muscle tension in their neck and their throat. So it kind of gets a little bit lazy, and it gets a little bit soggy, and it kind of collapses a little bit. And when that happens, they start kind of choking or gasping. And then they kind of stop breathing, and they'll stop breathing for 15, 30 seconds, sometimes much longer. And the brain says, uh-oh, no oxygen, wake up. So the patient will then wake up, but they don't wake up enough to remember it or know they woke up. So you could wake up many, many, many times a night and have no idea you did that.
How many times are we talking in the worst case?
I've seen patients tested that are doing this 30 to 50 times an hour.
An hour?
An hour. Yeah, absolutely, an hour and more. And so you can do this just again and again and again, and you wake up and you go back to sleep, and you wake up and you go back to sleep, and in the morning you go, man, I'm kind of wiped out, but I think I slept really good because I don't remember anything, and actually they've just been on the seesaw all night long. So they will wake up, back to sleep. If they turn on their side, they'll probably stop some of that. But they can do that all night long. Now, the definition of obstructive sleep apnea, I believe, is more than 5 of those events per night, which we would call as mild sleep apnea. But we see people that have hundreds of these every night. And then we bring them in and talk to them and say, hey, how did it go during the test? And they say, man, I slept great, no problem. And you're looking at hundreds of these events. And a normal oxygen, amount of oxygen in your body should be about 99%, maybe 97% in some cases, but in the high 90s, right? And so when they do this, you'll see their oxygen drop down to like 70%, 60%, and then back up, and then down again, and then back up. So all night long, they're hypoxic. And they do that every night of their life.
Why is it that the body doesn't wake you up enough to remember? Why is it just a jump start and then back, and you're kind of really not conscious throughout that time?
It's the way our sleep works. When our brain shuts down and goes to sleep, it's pretty good at doing that. And it just, when you look at these sleep studies, they don't actually really even open their eyes. They just kind of shake and move around a little bit and go back to sleep. And it's almost, if you've seen somebody sleep and they kind of twist and snort a little bit and go back to sleep, it's kind of like that thing. But they don't actually get up or open their eyes or look around. I mean, they're just not that awake.
If there is a partner in the bed next to you, what are they going to observe if they're awake and their partner's experiencing sleep apnea?
So really good question. Some of the best information we get is from the partners. And I'll never forget this story. I was interviewing a couple 25 years ago who he had obstructive sleep apnea. And she pretty much dragged him into the appointment. And I said, well, how bad is this? And she said, Doc, this is so bad that when we travel, we have to stay at separate hotels. I said, you mean separate rooms, same hotel? And she goes, no, because I can hear him wherever he is in the hotel. I have to have him be in another hotel. So the observations of the partner can be really important. It is usually them noticing the starting and stopping of breathing. So they snore, the snore gets louder and louder, then they stop for 30 seconds, then they start up again, and they gradually gets louder and louder and louder. So somebody who's snoring a lot at night and has these cycles of stopping to breathe and starting to breathe. But it can be less than that, or not as profound as that. It can be somebody who just has a gasp or a snort or a jump. And in some cases, the partner will say, well, I think she sleeps fine. I don't know that's any problem at all. And it may be that he's just so asleep he doesn't know. But the observations of the partner are really important. And it's usually about the snoring, the gasping, and it can be really frightening. We've had patients come in where they say, he actually stops breathing for a long time. I almost called 911 and I had to shake him, and I'm so scared I don't know what to do. And those are real observations. I mean, so the observations of the partner are really important. The observations of the patient are really important. But the connection has got to be when the patient comes in for whatever appointment, for the doctor to say, look, are you tired during the day? How's your concentration? How do you sleep? And a couple quick questions is all you really need to screen somebody in or screen them out.
So you mentioned how important the observations of the patient and partner are. Once you are reasonably suspicious that they may be experiencing sleep apnea, as a doctor, what would your next step be to confirm or deny that?
Well, you do look at their weight because that is a discriminator with the problem, and as that suspicion goes higher, then you basically want to describe to the patient what you're concerned about. I think you have sleep apnea, and I'm concerned about it, and we should probably talk sometime today about the consequences of that. But what we would do is we would test them, and there are a couple different ways people can be tested, and they're still evolving. One is you can screen them at home by simply hooking up an oxygen monitor to a clip to their finger, and say, clip this on your finger and hit the on button and go to sleep. And that will, if there are oxygen levels dropping during the night, that'll become a recording and a report that you can screen. Now, if their oxygen stays up most of the night, then it's unlikely that they have it. And if it drops, more likely. So it's sort of a screening test that then you would want to do more with. The next step would be what we call a sleep study. And most sleep studies used to be done in what we call a sleep lab, and we have one right here in San Andreas that we use all the time. And so we would say to the patient, it was actually kind of interesting, it still is interesting, as you would talk to them about sleep apnea, they would kind of give you the look like, yeah, I don't know if he knows what he's talking about, I'm not so sure about that. But then you would tell them, in order to do the testing, you got to go sleep in another bedroom in a sleep lab, and their eyes would get wide and they go, I'm not doing that. I am just not doing it. So what you do is you put them in a sleep lab. Usually they show up around 9 o'clock at night, 9 or 10 o'clock at night. And you hook them up to some monitors, and there's a bed, and it's a bedroom environment, and there's a technician there the entire time. And so they sleep all night, and in the morning they wake them up and say, you're done, and you can head home or go to work or whatever you do next. It's interesting that the people you offer that testing to are absolutely convinced they will not sleep. And they say, look, I'm not going to be able to sleep in that place, there's no way I can do that. And all of them go to sleep. All of them. I mean, it's just not a problem. I mean, they go in, they get all hooked up, and they're usually asleep within 30 minutes, and they sleep all night long, and you do the test. More recently, we're starting to do that testing in the home. Better technology, better computerized devices, and so we're more and more recently, and here in Calaveras, we're starting to do the testing in the home with good results. Much more customer friendly, much more relaxed for the patient, much more of a natural environment. Insurance pays for that testing for the most part, minus copays or deductibles, that kind of thing. So Medicare, Blue Cross, Anthem will pay for that. But you can do the entire test in one night's sleep. Now, the other thing we can do is what's called a split study, where you can spend, if you have sleep apnea, then we're going to try to figure out what we need to do to fix that. And one of the modalities we use is a mask with positive pressure that you wear at night to basically keep your airway open. Now, not so long ago, you would have to come in for the first study to get the diagnosis. Then you would have to come back later to figure out what mask, what pressure, how it works, whether it's effective. And so we've been doing split studies where you sleep 2 to 3 hours, and if your sleep apnea is so bad, they throw in the towel, they wake you up, they hook you up to the mask, they hook up the pressure, and everything you need is really done in one night.
Very nice. So it saves the patient from having to make that extra trip. But one thing I would be concerned about is how consistent are sleep apnea symptoms? Are there some patients who have it one night and don't the next? And so what if they didn't have those symptoms when you did the sleep study, but they actually did have them other nights?
Usually they have, it's not that they have them or don't have them, but they could have them a lot on one night and not have as many on another night. So on one night you might be diagnosed as a severe case, whereas on another night it might be not as severe, but you would still have it. It doesn't just totally go away.
It doesn't just go away. Okay, so you're going to see something during that sleep study if the person is suffering from it.
For sure.
Got it.
But there could be variations we can't reproduce in a sleep lab. For example, alcohol can play into this. And people that drink alcohol will have a lot more problem with sleep apnea. It causes a lot more muscle relaxation and a lot more of the tongue to fall back in the throat. So they don't drink in a sleep lab, so they could be much worse at home than they would be in the lab, but you would still see it.
Got it. Once you've identified that someone is suffering from these symptoms, what do you do next? How do you treat these symptoms?
Well, I think the first thing is to educate them, at least in my practice. I'm not about just throwing treatments at people without them understanding what's wrong. So I sit down and talk to them for a while. I tell them what obstructive sleep apnea is. I talk to them about why that's important, what they can do about it, kind of an educational thing. But then there are behavioral things people can do that I think are really fundamentally important. And I know the medical community keeps saying this again and again and again, but it's true. Weight loss makes a big difference. And what a great investment. With just weight loss, you not only treat your sleep apnea, but your joints feel better, your blood pressure goes down, your diabetes gets better, and your mental health gets better. So weight loss would be absolutely one of the first things you would try to encourage.
On weight loss, before we move on to other treatments, what is it about being heavy that is causing, as you were explaining, kind of a collapse of the throat is what's really causing the obstruction? Why is it that someone who's obese is causing that?
You know, Joel, I think there's actually a physical component to this. They tend to have bigger necks with more tissue, and they have their chests are bigger, harder to get air in. And I think there's a true physical component to this where their weight and sleeping on their back really helps obstruct their airway.
Okay, so just being on your back and having more weight in this area is just pushing down and putting, okay, so.
And more resistance down in this area, harder to get air in. And I think that's part of it, but it's probably more complex than that. There's probably some neurologic aspects to it, but by and large, if we can get people to lose weight, their sleep apnea gets better.
Is it advisable to say, let's give the weight loss a try before we did a secondary treatment simultaneously?
You know, if you had 3 of me in the room, you'd get 3 different answers. Weight loss is really, really hard. I've probably talked to 10 people today about weight loss in my clinic, and it is really, really hard, and that can be a long, long wait for a potentially serious problem. So I wouldn't be inclined to wait with this particular disease. With others I could, you know, like diabetes and hypertension, but with this particular thing, I would want to probably intervene while they're losing weight, if they can lose weight.
And how would you go about doing that?
Intervening?
Yes.
So the second thing they can do is if they are patients that are choking or gasping or snoring, turn them on their side. Get the partner to turn them on their side, or if they're awake enough, turn on your side or try to sleep on your side. We actually used to do a thing where we would tell them to wear a t-shirt when they sleep and to put tennis balls in the back of the t-shirt. And if you have tennis balls in the back of your t-shirt, you don't sleep on your back. You just don't. I mean, it's impossible. That sort of worked, not as well as we'd like, but it worked in some cases. But sleeping on your side works, weight loss works, minimizing alcohol can be really helpful. But then the real nuts and bolts of treatment are to use a device to generate positive pressure in your throat and in your airway, and that's a mask. Now, that's also evolving, but right now, if we were to write a prescription, there would be a mask you would wear. There would be straps on the mask, and it would be hooked to a computerized air compressor, is what you could think of it as, and it would generate a pre-programmed amount of pressure. It could tell when you're asleep. It would sneak up the pressure as you sleep more and make adjustments while you're sleeping, so that you get the maximum benefit. Some people don't like wearing the mask. When we prescribe the masks, I would say 25–30% just can't do it. They take the mask and they throw it across the room and they never put it back on. They just can't do it. But 70% can, and they feel so much better. They say, look, memory's better, fatigue is gone, I'm actually losing weight. There is a correlation between sleep and weight, that as you sleep better, it's easier to lose weight. But
in the last 2 minutes we have, what would some consequences be if this goes untreated that people would?
They're serious. So people that have obstructive sleep apnea are at a much higher risk for cardiovascular events. We think it's on the order of 3-fold higher. And we think their mortality is much higher than the non-sleep apnea patients. Definitely more hypertension, definitely more depression. And what's interesting and really tragic is that in the sleep apnea groups, they've done epidemiologic studies where there are many more motor vehicle accidents. Do they fall asleep at the wheel, or is it concentration? That's debatable, but people with sleep apnea do not do well on the road.
Okay. So this is a serious thing. People need to take it seriously and get treatment. If there's even a suspicion this may be something that's happening.
Absolutely. It's an epidemic. It's treatable, and it's fatal in some cases where you don't treat it.
Do you think that currently there's a large portion of people who do suffer from this and don't know and aren't seeking treatment?
Absolutely. That's why I'm here. That's why I'm here today, is because most of these people, I think, are not diagnosed.
So if you've experienced any of these symptoms that you've described, it's worth going to the doctor and asking some questions.
Go talk to your doctor. Just tell them, look, I'm a little bit tired. I'm wondering if I have this thing Smart talked about, and we can figure it out.
All right. Dr. Smart, thank you for your time and expertise as always.
Thanks, Joel. It's a pleasure.
And thank you for joining me on this edition of Inside View. I'm your host, Joel Metzger, and I hope you join me next time.